what are the relevant points to consider? Well, one is L5S1, as you all know, the crest position is going to be very important. Whether the facets are open or fused is also going to be relevant. The root position, I always try to look at it in the MRI with regards to the Cambin's triangle. Always take into consideration the pedicle anatomy because, in my opinion, when there's a severe spondylolisthesis at L5S1, what happens is the pedicle is dysmorphic. It becomes more elongated in the anterior-posterior axis, but it also becomes thinner in the craniocaudal axis. So it's a smaller pedicle screw, and your precision in placing the screw is absolutely key. The disc height obviously is relevant in those cases where the disc is collapsed. It may be easier to do your disc prep because it takes less time. Always look at that consideration. Take a look at the L4-5 level and take a look at the level below. Make sure that if there is a Bartoloti variation, you consider that in your construct. And also, I would recommend everybody to obtain a bone density study on everybody that's over 60 years old and anyone who's a smoker, regardless of the age. As it was shown previously by one of our colleagues, the taping technique that I'm doing now for very obese BMI 45 or greater, this was a BMI of 51. We tape over the top to the contralateral shoulder from the belly up, and also to do the same thing caudally and then across. So we find that this helps a lot with the X-ray technique. Everybody has a very similar operating room setup, and it has to be consistent. It has to be always the same, and I encourage everyone to use the same intraoperative team every single time. We're going to go to case one. This is a lady in her 40s, early 40s, who presented to us in 2023 with this image in the bottom right. And as you can see, in 2014, things didn't look that bad. What's interesting to me is how she progressed in 5 years from point B to point C. And also from point C to point D, you can see that level of compression in the nerve and the amount of pain that she was very significant. In flexion extension, she moved what I would consider to a grade 3 with what looked like almost auto-fused in that segment, but there's a little rim of bone gap that you can see there. So the footprint is very, very challenging. And so I told her before the surgery that we may not be able to do it. It was my first grade 3 spondylolisthesis after maybe about 125 cases. So I kind of jumped into the fire and gave it a go. One consideration that I want everyone to take a look at this is the proximal port. Consider that the proximal port in the skin, and then the distal port. The wire has some leeway, right? Has some leeway between the proximal and the distal port. So you can actually change the angle because you have the tricalcium phosphate waiting for you, and you can anchor that wire in a specific angle that's going to condition the way that the cage is positioned at the end. So my thought process with this case was that the wire placement was going to be key. So if you see in point 1, this is the first thing we obtained the pedicle, blood for bone marrow. And then the next step that I did was to place that wire into the disc space. Once we obtained that correct trajectory, the rest was the standard procedure. And I knew that I was not going to get a complete reduction. I didn't want to do a facetectomy and bring her back and obtain a complete correction. I just wanted to get her to a better place. And what's interesting with her is that she actually obtained a pretty good reduction, as you can see here, but also fused very well after 6 months. Her clinical symptoms completely resolved, and I was very happy about those things. Take a look at this picture here, how the screw is exactly and precisely within the pedicle boundaries. It's very, very important. And I think, nowadays people relying on robots and things. The X-ray does not lie, but the robot and navigation systems, they can create a 1 millimeter difference, and that is enough to bring your success to failure. Case number 2, another grade, I would consider this a grade 2 with vacuum disc phenomenon, listhesis of about 14, 15 millimeters. And we reduced it to just probably about 5 millimeters in this red line, because this is not measurable, because it's not calibrated, but we obtain a pretty good reduction compared to how things look, and a good distraction and a good cage placement. This was, I think, a 12 millimeter cage. Case number 3, very similar again, with this disc anteriorly with this listhesis, with a little bit of a disc fissure at the level above. This is a 42, 43-year-old female who's a security guard, works at our hospital. And she was very, very symptomatic, bilateral pars defects, and so we proceeded to perform the operation. 19 millimeters of listhesis, 16 millimeters in extension, 19 in flexion. And so I like to place the wires first, and then I go in with an 18 gauge, 8 inches needle, which is used for endoscopy, prior to making my incision for the cage placement. Why do I do that? I measure everything, and I calculate my entry point based on what Dr. Abbasi has taught me. And I also use sometimes the endoscopic way of getting into canvas, and I mix both measurements. But then before making the incision, I take what I think is the correct entry point, and I use the needle to guide me to the trajectory and tell me that indeed I am going to be able to get in there. I find this extremely useful, and I would encourage people to incorporate it when you're not sure where to do the entry point for your incision, especially in those cases with a little bit of morbid obesity or some anatomical variations. And the rest is the same: working channel, the distraction, and preparation for your cage placement. We obtain a decent reduction. This is a lateral listhesis case that Dr. Abbasi kindly requested me to show. This is a lady that had a laminectomy with facetectomy done by another surgeon in our city, who, when the patient failed to improve and basically collapsed, he decided to do a spinal cord stimulator. Patient came to us, and looking at these films, well, we decided two things. One, the spinal cord stimulator needed to come out because it wasn't really working, but then she needed stabilization and correction of her coronal deformity. So the easiest, simplest way was an OLLIF, which was accomplished in approximately 25 minutes. And the patient did very well, and her clinical symptoms resolved. I'd like to conclude the talk with basically three great areas here. One is the learning progression, right? So you need a hands-on proctor, and Amit guided me through approximately 12 cases on a hand-to-hand basis. And you start at single levels, L4-5, you progress to simple L5-S1, maybe a couple of levels with no deformity, and then you go to your grade 2 spondylolisthesis, whether 4-5 or 5-1, and maybe some coronal deformity. Your operative pearls, that I would like to share with you: the use of that spinal needle has proven to improve my precision in the entry point. Obviously, obtain perfect x-rays. Do not conform with just suboptimal x-rays. Retarget your trajectory. If you're not happy with the wire placement and you think your cage is not going to be an ideal spot, just go back and do it again until you feel that you have the ideal trajectory. In some cases, we've been completely unable at the L5-S1 level to get in there for reasons A, B, or C. And what we did in one case, we distracted after placing the pedicle screws, and then we did the cage placement afterwards. And I shared that with Dr. Abbasi about a month ago. I've done about 200 cases in the span of 3 years, which kind of correlates with Dr. Grunch. Her experience was about 600 cases, 6-7 years. So we're doing the same, about 10 a month, more or less. And I think, the progression has to be a common sense approach, right? So you can't start with grade 3 spondylolisthesis. You got to go from basic to more advanced. So careful patient selection. Talk to your patients, manage their post-op expectations, tell them about the radicular pain on the left leg. Obtain every single time the same type of preoperative film. So MRI, CT, AP lateral, flex X, and of course your bone density. I don't brace my patients. I early mobilize them. I try to get them up out of bed the first day of surgery, the same day of surgery, even if they stayed 24 hours, because some insurance companies are forcing us to admit these patients overnight. And so in those patients, I make sure they get at least 3 sessions of PT before they get discharged. I always follow my patients at 2 days. I like to clean the wound 2 days after with ChloraPrep and put a new dressing. I know it sounds a little OCD, but I like to see these patients, especially because they're being discharged so quickly. It creates and reinforces your bond with them. So follow up at 2 days, at 2 weeks, 6 weeks, 3 months, and 6 months. If they're doing okay after 6 months and CT scan shows good hardware fusion with no signs of issues, then we just proceed to discharge them. Overall, my experience with the OLLIF is that it has transformed my practice, and I'm very, very grateful to Dr. Bassi for everything he's done in teaching me this wonderful technique.